a Puscast covering the first 2 weeks of February 2017. References, as always, are available at edudoc.com, the home of my growing multimedia empire. And do you want to learn a little something every day? Go to ID Factoid on Twitter, or actually at ID Factoid on Twitter, and get a daily 140-character infectious disease pearl. But let's get on to the literature, shall we? I'm heading off for vacation shortly, so I'm going to try and plow through this with Warp Factor 9, which, if memory serves, does destroy the fabric of the universe. But I'm not much in the mood to do an in-depth podcast this week. But I'm sure it will remain fantastic. But let's get on to the literature, shall we? We start, as always, with viruses, and in this case, it's the Heartland virus. It's a case report of a death in Tennessee from this particular tick-borne illness, and unlike the prior cases of Heartland virus, the patient had not only a leukocytosis instead of a leukopenia, but also had an extraordinarily high ferritin, ranging between 32 and 46,000. That's Stills level ferritins. The patient succumbed to the illness. He had no underlying comorbidities of note, yet his multi-organ system failure resulted from viral invasion of virtually every tissue in his body. I doubt I will ever see a case of Heartland here in the Great Pacific Northwest, but sure is something. Heartland virus will show up on my boards. Flu continues to be pretty bad this season, and it remains elevated, but the good news is it looks like the vaccine is about 50% effective in preventing flu. Yay! And unlike prior years where we've seen buckets of H1N1, this has been an H3N2 that's predominated. Also of concern because older data suggest that H3 influenzas are more associated with cardiovascular events. But when you break it down, the vaccine was 43% effective in preventing H3N2 and 73% effective in preventing influenza B. Not great, but it sure beats dying of influenza on a ventilator. A little more concerning is there was a spike in H7N9 bird flu deaths in China, and the circulating bird flus are always a worry. If they should jump to humans, which wouldn't be that hard, we could really have a pandemic to rival that of 1918. Just a reminder, this study demonstrated that patients with HIV get non-AIDS defining cancers, and they get it often at younger ages, and also depending on the CD4 counts. The cancers that were found at younger ages compared to a general population were lung, anal, oral, kidney, and myeloma, and that having low CD4 counts was especially associated with developing lung cancer. Back in the day, I used to not care if my patients still smoked because they were only going to live 6 months tops. Now it's critical to get your patients off the evil weed so that they don't go on to get lung cancer earlier and die of it due to perhaps accelerated cancer progression. And patients with HIV often are infected with multiple other viruses. This study looked at the rates of viral shedding in semen in HIV patients and found not only was there HIV, but herpes viruses in semen, CMV, EBV, HHV, especially HHV7, could be found in HIV patients' semen. And how much these viruses play a role in HIV transmission is yet to be determined. I know the Navy is very concerned about the replication of herpes viruses in semen. Oh wait, wrong semen, sorry. Yep, mumps is booming as well. We're having an outbreak to the north of us in Washington, not Washington State, we just call it Washington here. And there was a report in CID of a mumps outbreak in a university a couple of years back. The important thing to note is mumps can occur in a highly vaccinated population, such as a university population, and they missed the initial diagnosis of a patient with parotitis because they relied upon the IgM. If you really want to diagnose mumps, you need to do a PCR, to prove or disprove the diagnosis, especially in a vaccinated population. Of the 56 cases, 3 were hospitalized and 2 developed orchitis. They do not mention that I can tell whether or not the index case was vaccinated and the potential source of the index case. Did he come back from a third world country recently or something? So you don't know that information. But mumps, like many vaccine-preventable illnesses, are on the rise. I may yet get to see a measles case before I retire and or die. In some states, like Oregon, which is the worst or one of the worst for vaccination rates, is primed for a good outbreak. Yay! I had mumps as a kid. I have Super 8 film to prove it. Really. But when tested, I had no antibodies, so I'm getting boosted with an MMR. I hope those tracking nanobots are better than they used to be. I think we all know this, but somebody needs to prove it. This study looked at a large population, 29,683 patients, of which 7,375 had diabetes. And if patients had diabetes, they were much likely to be hospitalized for infection. Hazard ratio of 1.5. And that risk went up if they were insulin-dependent diabetics. So now at least you can put a number on the risk. Interestingly, they did not find an association with 28-day mortality. That kind of surprised me, but upon reflection, I don't think diabetics die at quite the rate they used to in the hospital from infections. It's been a long time since I've seen some nasty diabetic infections, so I think we do a better job across the board than we did, say, 20 years ago. And if you're bored, name that logical fallacy. I'm going to go out on a limb here and suggest that while nice in theory, safe sex ain't going to work as a single intervention for preventing the spread of sexually transmitted diseases. The French did a study, the Hypergay, which I think is the name of the flooring I have in my kitchen. Anyway, patients received doxycycline after sex, and they had a 47% drop in sexually transmitted diseases, specifically gonorrhea, chlamydia, and syphilis. And it was statistically significant for chlamydia and syphilis. This was a poster. It's not a published trial yet, but the future of prevention of STDs probably lies in pre and or post-exposure prophylaxis, depending on which STD you're concerned about. There's certainly downsides, such as breeding resistance, but that's happening anyway. And given that almost 3/4 of the men in this study were asymptomatic for their STD, waiting for symptom treatment to help stop the spread of infection seems to be a non-starter. Regular listeners are well aware of my propensity for yammering on about how infections are bad long-term because of cardiovascular issues. This study looked at 173 patients who had severe pneumonia, and their 5-year mortality rate was 57%. That's pretty good. And what they die of? COPD and, drumroll please, cardiovascular disease. The patients did have comorbidities such as prior myocardial infarction and diabetes mellitus, which would increase your risk of having a cardiovascular event. But still, infections are bad for you, and they kill you often later with cardiovascular disease. The rule is usually the sicker you are, the worse you do. The more comorbidities that you have, the worse you do. And if you have MRSA bacteremia, that tends to be true. But what is associated with a better outcome? Infectious disease consultation. Don't leave home without it. For example, if you have endocarditis and staph bacteremia, your odds ratio is 4.5 for death. If you have septic shock, it's 4. If you get an ID consultation, your outcome at day 7, your odds ratio is 0.1, and at 30 days, 0.4. It's amazing what expertise will do for patient care. What do you want to know about Clostridium difficile from the last 2 weeks? Well, if you want to get rid of your outbreaks, you got to get rid of quinolones. Okay, fine. That vancomycin is associated with decrease mortality for severe C. diff, something we've gone back and forth with over the years. But this retrospective study looked at 10,000 patients and found that vancomycin had better outcomes if you had C. difficile. The other thing in a meta-analysis suggests that if you're going to prevent C. diff with antibiotics, you need to give your probiotic around the time of the first dose of antibiotic, and that the further you are out from the beginning of the antibiotic, the less efficacy you got from your probiotic. So if you're going to give a probiotic, try and give it right away. And finally, and I think this is important in terms of cost and patient care, they found no increase in C. difficile in this hospital when they got rid of isolation. No contact isolation, no spread of C. diff. They did not have the hypervirulent strains, but they also did not have any outbreaks. And they did not do contact isolation once there was no incontinence and patients had dedicated toilets. So I would add C. diff to my list, along with MRSA, of infectious diseases that really don't need contact isolation in the hospital. Although I think it's incumbent upon systems that do this that their hand hygiene is uber punctilious. That's how you get a ride for your punctilious. You get Uber. There was a headline that talked about the Uber businessman, and I thought it was some super businessman, but it was just a guy that runs Uber. Although be wary as to who you give your probiotics to. There were 7 cases of Saccharomyces bacteremia or fungemia. It was S. boyardii in patients who received probiotics. They were all severely ill patients in the ICU in India, but they compared the bloodstream to the probiotic and found the S. boyardii was the same. So be careful which kind of probiotics you give. I think we need to do a study on Hefeweizen and whether or not that would prevent C. difficile diarrhea or antibiotic-associated diarrhea. And with enough Hefeweizens, who cares if you have diarrhea? Ibrutinib. It's a Bruton's tyrosine kinase inhibitor. It's used to treat lymphoproliferative disorders. Lymphoproliferative. One of those wonderful words. Anyway, patients on this medication may have an increased risk for cryptococcus. There were a couple of cases in the initial trials, and subsequently there are 2 case reports in open forum infectious diseases of cryptococcal disease in patients receiving Bruton's tyrosine kinase inhibitor. The interesting thing is neither patient had inflammation in the spinal fluid. And there are also reports of invasive aspergillus in patients on this medication. You might remember that there is this thing called nodding syndrome, NODDING, a form of seizures in sub-Saharan Africa that was of uncertain etiology and was progressive and fatal in children. It looks like the cause of this is Onchocerca volvulus, a parasite. You might know it better as a cause of river blindness spread by the bite of a fly. And apparently this is not a direct invasion of the parasite into the brain, but cross-reaction and autoimmunity. They found that kids had antibodies directed against human tissues, specifically to leomodin 1, if I pronounced that right. So nodding syndrome may be more like rheumatic fever than an acute infection. Of course, this needs to be investigated further, but it's certainly intriguing. And that's it, really. This may be the shortest Puscast ever, but I really didn't find a lot of articles, and I'm going on vacation in 12 hours. All the good stuff is here, don't worry. So that ends the Puscast. You can find references at edgydoc.com. Don't forget the ID Factoid Twitter feed if you want to hear these references again in less than 140 characters. And with that, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along. Thank you, in dictation, and goodbye.